Your screen is visible, ma'am.
Good evening, everyone. So I'm Dr. Vanmati. I'm a pediatrician from Chennai. It gives me immense pleasure to welcome you all for this webinar on Pediatric Pathshala. This is the Guiding Light to Excellence. This is module 2. This focuses mainly on rational use of antibiotics in pediatric practice. So we have successfully completed a module 1, which was on rational use of antibiotics in respiratory tract infections. So in this module, we are conducting scientific CME series on rational use of antibiotics in pediatric practice. There is also interactive question and answer platform, and there are also videos on expert view to excel pediatric practice, and there are also updates on antibiotic resistance. So this is our Pediatrician Pathshala platform, in which you can click this icon, and then you can download the books on book like Ped Companion and Rational Use of Antibiotics. So the videos discussed in module 1, they're all uploaded here, and you can click here to watch, click the icon to watch. And the videos which will be discussed in module 2 will also be uploaded here. So going on to a topic proper for today is antibiotic stewardship and respiratory infections, current scenario and way forward. So our speaker for today is Dr. Bhaskar Shenoy, and our moderator is Dr. Pramod. So let me introduce the speaker, Dr. Bhaskar Shenoy. He has completed his MBBS, MD Pediatrics, FRCPCH UK, Fellowship in Pediatric Infectious Diseases, Diploma in Infectious Diseases, and Fellowship in Applied Nutrition. He's a chairperson elect IAP Infectious Disease Chapter 2024. And he's also the head of the Department of Pediatrics and Chief of Division of Pediatric Infectious Diseases, Manipal Hospital, Bangalore. And he is also the coordinator for IAP Infectious Disease Fellowship in Pediatric Infectious Diseases. And he was a member of Advisory Committee on Vaccination and Immunization Practices during the period 2017 and 2022 to 23. He is also the adjunct professor of pediatrics, Manipal University, and he is a managing editor, Pediatric Infectious Disease Journal, and he was the honorary secretary at IAP Infectious Disease Chapter during the period 2022 to 23. So let me introduce the moderator for today, Dr. Pramod. He has completed his MD, DNB, and FAAP. He is a professor of pediatrics, DY Medical College, Pune.
Ma'am, can you just make it on slideshow mode?
Yeah, sure. So our moderator for today is Dr. Pramod. He has completed his MD, DNB, and FAAP. He's a professor of pediatrics, DY Medical College, Pune, and he was a president IAP 2016, and he was a standing committee member in International Pediatric Association, and he was the ex-vice president in Infectious Disease Chapter IAP. So I also like to welcome the eminent speakers from all over India, from places like Andhra Pradesh, Bihar, Delhi, Jharkhand, Haryana. Welcome you all, speakers. And in this and after completing the meeting icon, and this participation certificate will be looking like this. So I would like to hand over this session to Dr. Pramod. Over to you, sir. Thank you.
Okay, so it's a great evening with so many of my friends and colleagues from all over the country attending this particular webinar. And myself and Dr. Bhaskar Shenoy, they are virtually present to discuss issues related to the respiratory infections in pediatric practice, the antibiotic therapy, and so on and so forth. And we first of all must tell that we are jealous of all of you because you are having nice starters and food, but we are just looking at you. Doesn't matter. We will have it at your individual city sometime. Anyway, now today we all see that monsoon is rampant everywhere. And in addition to the viral infections like dengue and chikungunya and so on and so forth, we also have so many respiratory infections going on. And respiratory infections are nothing but our bread and butter. So if children stop having cough, cold, and noisy breathing, then we will also stop our breathing, isn't it? So it is important that we know a bit about everything in the respiratory system. That is extremely important. And respiratory system means it starts from nose. So it might have rhinitis, which usually is viral. It is tonsillopharyngitis, which in majority of cases is again viral, but in 30% cases it is bacterial. And you know that group A beta hemolytic streptococcus is the most common bacterium. Okay. Then the friends of the upper respiratory system, that means the adenoids, the sinuses, and the ear, they are, the friends. But then rhinosinusitis in most of the cases, 70%, it is bacterial. Otitis again in 70% cases is bacterial, and in 30% it is viral. And our common three organisms, the Streptococcus pneumoniae, Haemophilus influenzae B, and Moraxella catarrhalis, they are the common bacteria. So when we go down, we have croup, and then we have tracheitis, we have bronchitis, bronchiolitis, and pneumonias. So it's a big spectrum. However, there are some common principles which they are underlying all these infections. Okay, and it is necessary that we know the intricacies of these various infections which attack different parts of the respiratory system. We are all aware of the basic facts, like viral infections means they are generalized. So a child who has runny nose, who has red eye, and who has rash, and so many other things, usually we know it's something going on like a viral infection. While bacterial infections are localized. So if there is involvement of the tonsils in the form of follicular tonsillitis, that particular child may not have pneumonia. And conversely, if a child comes for pneumonia, usually he won't have follicular tonsillitis. So they are very, very localized. And viral infections, in general, children are playful and they play, they eat, and they smile. So that's viral. And mother says that when the fever is down, he is quite fine and starts fighting with his elder brother or sister. While bacterial infections, the fever comes down with paracetamol, but the child is still not playing, the child is dull, and the mother says he is not his usual self. So we need to differentiate the two. And in viral infections, of course, more than one member in the family is involved, and more than one family in the community is involved. So we have to be very, very clear, at least clinically, whether we feel it is viral or bacterial. However, some of these viruses like adenovirus, which have started deceiving us because, they present, like something else, they turn out to be something else. And if time permits, we will discuss about that also. So we are going to discuss various things as to what is the duration of therapy for otitis media, how do we handle otitis media with effusion, then about rhinosinusitis. If the discharge from the nose is say purulent, does it really mean that it is bacterial? Then whether do you have anything like a short course therapy of antibiotics for pneumonias, and so on and so forth. Then there is one test which is called rapid antigen diagnostic test, whether it is having any role in our day-to-day practice in the group A streptococcal infections and all. So to discuss all this, we have Dr. Bhaskar Shenoy, who is an authority on infectious diseases and already has been introduced. He's a expert, and he will be the president of our infectious disease chapter next year, and he will give you clarity of concepts related to almost all the points which I just put forth in my introduction. So Dr. Bhaskar, I think let us start with the presentation, and maybe after your presentation of say 40-45 minutes, then we can just have some questions and answers from our colleagues, and I think you can just share your presentation. Thank you.
Thank you, Dr. Jog. Thank you, Team Microlabs, for giving us the opportunity, at least virtually, to discuss some of the important topics. First, let me share the slides. Yeah. Yeah. So as Dr. Jog has told, today I will be discussing rational antibiotics in respiratory tract infections. In fact, as it has been told by the moderator, that it is a huge topic, but 45 minutes is very less, but still I will try to concise and put the basic things, put what is take-home message and what has to be done in our clinical practice. All those things we will be touching upon. So as we know, the respiratory tract infections cause a significant healthcare burden worldwide. They consume lots of resources, and the best part is most of them are trivial and they are self-limiting. But sometimes they may cause a lot of mortality or morbidity if not diagnosed and treated early. Example, pneumonia. And they are the reasons for irrational antibiotics, and they are responsible for the over-prescription of the antibiotics. When it comes to the upper respiratory tract infection, again, it is one of, as Dr. Jog has told, it is one of the frequent causes for in the outpatient, frequent cause for medical visits and antimicrobial prescription. Most of them are viral and they are benign. And in spite of this evidence that it is benign, it is self-limiting, it is viral, but still there is an increased tendency to use or abuse the antibiotics. And in the end, it contributes to the AMR. And they cause even a lot of side effects and adverse events, and it adds on to the unnecessary cost of the treatment. When we look at the problem, the burden of the problem, more than 1 in 5 pediatric patients who come to the pediatrician, it results in antibiotic prescription. It is not only in a developing country like India, and even what is said that if you look at the US data, it accounts for nearly 50 million antibiotic prescription annually in the US. And inappropriate antibiotics prescription, especially if you are URI, is very common, and 10 million prescriptions per year are directed towards respiratory conditions, mind you, for which they are unlikely to provide benefit. That is the irony of the problem. So the recent evidence they suggest that the broad spectrum antibiotic prescription has increased, and it occurs when either no therapy is necessary or narrower spectrum antibiotics are more than enough. So I will just take you through a study which is in China, wherein they looked at the antibiotic prescription pattern of recurrent respiratory infections in a rural primary health care center, where they looked at the 46,000 plus cases, and it is astonishing to see that 83% of them received at least one antibiotic as a part of their first prescription. That is so sad state of affairs, and we are not far behind this. Out of the 38,000 sampled cases with the antibiotics, 40%, 56 and 31% respectively received either parenteral antibiotic, broad spectrum antibiotic, or 2 or more antibiotics. And everyone, it was a part of the prescription. And the top 5 antibiotics that were prescribed were penicillin, about 30%, third generation cephalosporin, again around 29 to 30%, macrolides 25%, first generation cephalosporin about 23%, and second generation around 10% in the same study. So such overuse of antibiotic, it causes a lot of antibiotic resistance, and new antibiotics are very less in the pipeline, which we cannot dream of in the near future. So growing health and economic threats of antibiotic resistance, we need to be very cautious, very judicious in the antibiotic prescription. This becomes an urgent public health and patient safety profile. So we need to have a judicious prescribing strategy, and most of the upper respiratory infections, either AOM or acute bacterial sinusitis or streptococcal pharyngitis. And we need to have a stringent criteria for the diagnosis and management of these common respiratory infections. And we need to look at the strategies that should weigh the benefit and harm of the patient. There is a differing approach, various differing rates of bacterial infections, and they require different approaches. For example, acute rhinitis, laryngitis, tracheitis, mainly caused by viruses, and antimicrobials are never needed in such cases. Whereas pharyngitis, it could be a bacterial also, and that time we may have to go for that. Then how do you recognize or differentiate these things? We need to have a scoring system to detect or in a viral and a bacterial infection. We may have a rapid diagnostic test which can diagnose or differentiate between the two. And bacterial infection, we say bacterial infection needs antibiotic, but it is not that always bacterial infection needs antibiotic. Some of the bacterial infections may have a spontaneous resolution. It's not that every bacterial infection may need antibiotics. And this particular thing has has an implication that the antibiotic will help only a small portion of the patients when the infection is known to be bacterial. And as I told, the natural resolution rates are, you will be surprised to see this. AOM, the natural resolution rate is about 80%, more than 80%. And in streptococcal pharyngitis, more than 90%. And acute sinusitis, it is around 60 to 70%. So the clinical decision making, whether to prescribe an antibiotic or not, is always a dilemma. And we need to look at the differential points. And today we are going to emphasize on how to differentiate between these two and how to rationalize our treatment. So what is the current practice? Currently, commonly we use antibiotics, or what are the conditions we see in practice is, one is non-specific URI, pharyngotonsillitis, and otitis media. As I told, most of the time they don't need antibiotics. When you write an antibiotic, you should ask yourself at least 4 questions. One is perception of the need. Is an antibiotic necessary? You ask yourself, just spend few seconds. Choice of antibiotic, which is the most appropriate antibiotic for that particular condition. And what is the dose, route, frequency, and duration? Because duration also matters. Sometimes you keep on giving for a longer time. There are various advances to and papers and recommendations to tell that now they are looking at a shorter course of antibiotics and monitoring the efficacy. So in the nutshell, when we talk about the antibiotics, when you use inappropriately and excessive antibiotics, it causes antibiotic resistance, and that causes failure of the antibiotic treatment. And again, this vicious circle goes on. So with that, let me take you through a few cases which are commonly seen in the outpatient. 1-year-old male with a 2-day history of fever, cough, and rhinorrhea. He has red eyes, nasal discharge, mild throat congestion, and some other members in the family are also having the mother and the elder sibling. So if you look at the throat, maybe if you clearly see there is some congestion, but it is not typical of bacterial infection, because viral pharyngotonsillitis is very common. These are the various viruses in 60 to 70% of the cases: rhinovirus, influenza, parainfluenza, RSV, adeno. These are the various viruses that can cause pharyngitis. So it is not that every time thyroid complaints of throat pain, every time you see a congested throat, it is bacterial. It is most often it is viral. Then what should I do? Should we need a CBC? No. Throat culture routinely not required, and only a general symptomatic treatment. And in these cases, antibiotics are not required. And there are other viral etiologies which you can clinically detect. For example, hand, foot, mouth disease, or measles, or other viral infections. You can always look at the clinical features, look at the throat, look at the lesion, and of course, most often you can diagnose that these are viral, which may not need antibiotics. So there are some examples like adenovirus, which causes the palpebral conjunctiva, the sandpaper-like. And then EBV virus also can have a patch on the tonsil, but the tonsils are not red and congested. Herpangina, the small ulcers on the pharynx, and a small erythema may not be bacterial. So what I'm trying to tell is that more than 80% of the URI in the practice are viral. And some non-bacterial like keratosis, aphthous ulcers can be there. And the bacterial, most often it is a group A beta hemolytic streptococci, and other bacteria like group C and G streptococci, corynebacteria, mycoplasma, etc., can cause this thing. But pneumococcus and Hib in the throat swab, sometimes if you happen to isolate these things, it is not always a pathogen. It can be a colonizer also. Then what about the throat culture? Can I do a throat culture and find out it is? No, it is a very cumbersome process and unnecessary, adds to the cost. Only in certain conditions where you clinically think that it is a bacterial infection, it is a more of a rule-out test than a rule-in test. And people argue that I am more bothered about rheumatic fever and I have to give early antibiotic. No, you can wait up to 9 days for the antibiotic to be started in case, because before that, even if you start, it will not decrease the ability to prevent rheumatic fever. So you have sufficient time to differentiate between a bacterial or viral infection. Don't do the throat culture regularly. It should be sent only in suspected streptococcal pharyngitis. What is that suspected? I'll come to that. So management here again, you have to give symptomatic treatment. Let me take through a second case, which has fever, poor feeding, diminished activity, 4-year-old with no exanthema or no similar history of other cases in the family. But he has pain and difficulty in swallowing even with the liquids. So you now know the difference between the previous case and this case. You can see the throat. There are various marks I have put. One is there is a patch on the tonsil. The uvula is congested and red, beefy red, what you call. The upper fauces is congested, and the tongue is more of a gray or furry tongue. And so looking at the throat, just a simple clinical examination, you can easily diagnose or differentiate between the viral and bacterial. So if it is a bacterial, you have a swollen uvula, you have a red swollen tonsil, white spot on the tonsil, red swollen throat, and gray or furry tongue. Whereas even in a viral, you can see red swollen tonsil, but there is no patch. Throat can be congested. So this is a simple method to differentiate. Then do you have a criteria to suspect group A beta hemolytic streptococcal pharyngitis? Yes, there are various clinical criteria which are very simple to practice. Even it doesn't take 1 minute if you are an experienced pediatrician. And tonsillar exudate, tender anterior lymphadenopathy, fever, and absence of cough. These are the 4 things you have to look for. One is fever, absence of cough, anterior lymphadenopathy, cervical lymphadenopathy, and tonsillar exudate. And those with less than 3 points are unlikely to have group A streptococcal pharyngitis. So now let me compare these 2 cases. And when you compare, you will get the answer. The first one had acute onset with red eyes and some kind of cough. Pharyngeal congestion was there, but there are no cervical lymphadenopathy or exudates. And age is another thing. The bacterial pharyngitis or sore throat is very uncommon in a child less than 3 years. So most probably the first one is a viral. And second one, if you compare the acute onset, a severe throat pain, rapid progression, follicles, lymph nodes, toxicity, age of more than 3 years, this is more of a bacterial infection. So now you know how clinically or in the busy practice, you can differentiate between a viral and a bacterial. Do I investigate or do I start an antibiotic? So investigations are not required. ASLO is not required. But only thing is, most of them are clinical diagnosis. No routine investigation. Only thing is, when you are in doubt, you can use the take the help of RAD, that is rapid antigen detection tests. So let me tell you what is the utility of this RAD. It is more specific of about 95% and sensitivity is 70 to 90%. It is cost effective. And there was a paper in the National Medical Journal by Dr. Balasubramaniam. He has done a study on the utility of this thing, and he found, and he now also he does routinely this particular test in his practice. So it is a very simple procedure wherein streptococcal, the two marks are there, the control, and if it is positive, you get the second line when you put the sample in the sample well. This is very simple. Within 5 minutes, you can tell that though the availability is less, but when we start doing it more, probably the availability will be more. And it is a cost effective in the sense it is not more than 200 rupees per test. So it is such cheap, but we are not utilizing it more. So it is an excellent point of care test, and turnaround time is around 5 minutes only, sensitivity of 96%, and cost effective. And this should be propagated as a part of antibiotic stewardship, avoid antibiotic abuse. So this particular child, should I treat? Yes, here you should give antibiotic. The first case, you should not give antibiotic. And in the second case, you should give antibiotic. Why antibiotic? Why? Because it one is it will prevent the complications. The suppurative complications can occur, recovery can, and spread to one can occur, and non-suppurative complications like rheumatic fever also can be prevented, and especially when it is given up to 9 days, which I told. So which antibiotic? Though we say textbook, if you say penicillin is the first choice, penicillin is not available. So amoxicillin, 50 milligram per kg twice daily for at least 10 days. And mind you, the duration is very important. Most often, we need to advise the patient that it should be taken for a proper duration. Generally, they after 3-4 days, when the child becomes okay, they tend to stop, and then again recurrence and other complications I have seen a lot. And this is a chart which can be seen in any other standard textbooks. So management protocol, examine the eye, ear, nose, and conjunctivitis, coryza, hoarseness is there. Viral, you give symptomatic response. Whereas purulent patches, toxic lymph nodes, and it is bacterial. Antibiotic, either you do the RADT or culture, and if the culture is positive, I mean the culture or RADT is positive, you give antibiotics. So in summary of this particular cases are that you should suspect bacterial tonsillitis in a clear older child. Rapid antigen test is a very good test, and there is no hurry to start antibiotic. Even you can wait up to 9 days. By that time, most of the viral will subside. Amoxicillin is the first choice, and treatment duration has to be 10 days. The next case, 5-year-old comes with fever, headache for 3 days. Child had of upper respiratory pharyngitis, tonsillitis, and had improved. Now he has purulent nasal discharge and periorbital edema and tenderness on maxillary sinus. Naturally, the diagnosis will be sinusitis. So when do you suspect sinusitis? Sinusitis when the symptoms are persistent, when the symptoms are severe, and there is a new onset fever. The child had respiratory infection, recovered, or it is persisting, and new onset fever. So these 3 points you have to remember: persistent, severe symptoms, and new onset fever. So again, the microbiological pattern is same for most of the respiratory infection: strep pneumoniae, H. influenzae, and moraxella, and sometimes the strep 5 genes. So Treatment is all symptomatic, pain relief, nasal symptom, and antibiotic. Antibiotics, it is amoxicillin or amoxiclav. The other things come last in the list. So amoxicillin, you start at 40 milligram per kg in 2 divided dose, but the duration should be longer, at least for 2 weeks. And if no response, you have to give co-amoxiclav. Has to be started if you don't see response. And in this particular case, again, these are more common in the school going age. A viral rhinitis which starts and persists for a longer time. It's a clinical diagnosis. There is no need for any X-ray or CT or MRI for diagnosing the sinusitis. Most of them are respond to amoxicillin. They don't respond within 48 hours. You go for amoxiclav. So next child, 1 year, 3 months, fever of 2 days, rhinorrhea, excessive crying for 4 hours. And you know it is acute otitis media. How should I evaluate? So you should have a otoscope in your clinic. You should have a pneumatic otoscope if possible. And you try to look at the tympanic membrane, the mobility, the position, the color, and the opacity and the landmarks. So if you look at these things, you know the one in the left ear is the congested, and you have the acute otitis media. And we have to stratify otitis media into severe or non-severe. And severe means unresponsive pain. You're given some paracetamol, still the pain is there. Child is toxic and child has high fever. Whereas non-severe, he has some intermittent pain and there is a response to the analgesics and there is mild or no fever. So management, again, some saline nasal or paracetamol, but the antibiotic, it is a huge congested slide, but the child with the less than 6 months, if you look at, if you get a case, it should be started with the IV antibiotics, either Ampygenta or ceftriaxone. But an older child, 6 months to 2 years, you need to give amoxicillin. But it is more severe case, you have to start with co-amoxiclav, around 45 to 50 milligram per kg. And mind you, the duration should be at least 10 days. That part you should never forget. You should educate the parent that it should be taken for the entire duration of 10 days. And if the resistant OM, that is, if there is no response even after 48 hours, if you have started amoxicillin, switch over to co-amoxiclav again for 10 days. So similarly, there are other age group wise, but amoxi or amoxiclav becomes the first drug of choice. Even if you look at the national treatment guidelines of the government of India, 2016, and that also recommends amoxiclav as the first choice, amoxicillin or amoxiclav as the first choice for treatment of these things. So this is an algorithm for treatment of AOM with the severe symptoms, treat with the antibiotics, follow up on 10th day. When there is no severe symptoms, if look at the age of the child, less than 2 years, bilateral antibiotic use. And unilateral, observe and treat with the antibiotics if it worsens. And deterioration, if you observe deterioration, give antibiotic. In a child more than 2 years, follow 48 to 72 hours. If the symptoms persist, you treat with the antibiotic. So we need to use the antibiotic judiciously, have a pneumatic otoscope. That is more important. Now let me take you through the next case. Let me go down little into the chest. 2-year-old, fever, cough, breathlessness, 2 days. His saturation is maintained. He is febrile, tachypnic, and reduced air entry. So whenever such cases come, you confirm the pneumonia first, look at the etiology, and grade the severity. These 3 things you have to do it. When the child comes with cough, fever, and hurried breathing, 3 things you do. This is a simple thing. Confirm that it's pneumonia. think of, suspect a possible etiology, and they grade the severity. So in this case, you can see a opacity in the right upper and mid zone. And what is the etiology? What is the severity? Again, in the respiratory infection, Streptococcus pneumoniae stands first. And all age groups, it is the Streptococcus pneumoniae. Whereas a very young child, they can have chlamydia, viral, etc. And below 5 years, the next choice is RSV. And more than 5 years, the mycoplasma or the atypical organisms also come. So we can, depending on the age and depending on the symptoms, we can suspect it's a tentatively it can be streptococcus or a virus or atypical organism. But it is very difficult clinically to differentiate between viral and bacterial pneumonia. It is humanly most of the times it is not possible. So it always, we start, moment a diagnosis of pneumonia is made, we start with antibiotics, whether amoxicillin or amoxiclav, plus whenever a older child who is relatively stable, who has some manifestations of atypical pneumonia, we also add azithromycin also. So non-severe pneumonia, amoxicillin, amoxiclav, and add azithromycin in case it. So the question now, can we use multiplex PCR in the microbiological diagnosis? In the rationalization of antibiotic, does it not play a major role? So to answer this question, I will take you through one more case. A 2-year-old child, fever of 6 days, cough, fast breathing, and they had tachypnea and tachycardic, nasal flaring, subcostal retraction, grunting, and he was admitted in a private nursing home, and they did the nasopharyngeal swab, and which showed human metapneumovirus. They treated for 2 days. This is a it was a VIP patient. So they treated for 2 days, but the child worsened. And this is the picture, something like a ARDS. And ventilated, then shifted to our hospital. And when we were intubating, the intensivists, they took tracheal aspirate for multiplex PCR, and meantime ceftriaxone vancomycin was started, and the report came. Streptococcus pneumoniae detected. Of course, human metapneumovirus was detected. So now we know what is the bug that is causing. We have a microbiological diagnosis. So Streptococcus pneumoniae, and it helps in a de-escalation of antibiotics. The vancomycin and other things were stopped. Only ceftriaxone was given, and slowly the child improved. So in this background, we get a question: what are the pros and cons of respiratory panel in making a diagnosis? So you have what is called the upper respiratory panel and a lower respiratory panel. Upper respiratory can be from throat swab, nasopharyngeal swab. Lower can be from ball or sputum or ET aspirate, depending on the condition. But the limitation is that you can detect only those organisms for which there is a target, which primer is there. And it cannot give comprehensive antibiogram like a culture. So if you look at the culture, even if you're not suspected on a particular antibiotic, it is coming. And colonizer and pathogen is difficult to take, especially in the upper respiratory area. Streptococcus pneumoniae can be a colonizer also. And this doesn't differentiate between a colonizer and a pathogen. The next problem with these things is this is a PCR. PCR is detecting the DNA, and it cannot differentiate between a living and dead. So you cannot take it as a end of therapy test. Respiratory panel, in the nasopharyngeal swabs, you have a lot of things, but the sensitivity and specificity, especially of the ball and the sputum, are very good. You also have a rapid influenza diagnosis test for these things, which has a greater sensitivity and it improves the diagnosis, and it has helped definitely in reducing the use of antibiotics when not indicated. So continue with the antiviral treatment whenever it is positive, and even you clinically think that it is a influenza. The next case, a 2-year-old child who has acute onset of symptoms, looks like a upper respiratory symptom. The mother says child is having loud, dry, brassy cough or a barking cough, but he is fine. It looks more like a laryngitis, and cough character is changed. So laryngitis naturally. He was active, and rhinitis was there. It is naturally the type of cough, the barking loud cough, high-pitched inspiratory noise after coughing and crying, and is absent at rest. This means it's a acute viral cough. So what do you do for these things? You just do the symptomatic treatment and just parental advice that if he doesn't feed, he is agitated, stridor or the sound worsens, retraction worsen, you come back. And this child has now come back with a stridor at rest. He's crying, but the parameters are okay. I mean, saturations are 92, minimal retraction. So he has a moderate cough. So how do you treat? So whether it is a moderate or severe, there is no role for antibiotics. It is only nebulized adrenaline. Sometimes they may need oxygen, and steroids sometimes, yes. Otherwise, most of them, they respond well with these things. There are sometimes we get cases wherein they come with recurrent coughs, and they would get multiple courses of antibiotics, cough syrups, and all tests are done. And this is the time, generally it happens when this child starts going to a school, and this has a recurring pattern, and the parents are always concerned. And such cases, again, they do not need antibiotics. They need, it is a viral respiratory infection. So we have to differentiate between a viral and bacterial. So there are some difficult dilemmas in antibiotic use. There are some scenarios. So there are one scenario is wherein the immunocompromised child, the first one, where you have to give antibiotics, you have to start immediately. Otherwise, the child will get either a bacterial superinfection or the worsening of the symptoms, because he is immunologically at a lower distance. And there are sometimes the second option is a parental demand for antibiotic when it is really not required. For example, a child comes with a running nose, child comes with a wheeze, then our job becomes to educate the parents, educate the risk of antibiotic, educate that the what is the long-term effects. So this is what we have to do. Then there is third scenario wherein a pneumonia comes, and probably it is caused by a bacteria, where we need to give antibiotics. So treat with amoxicillin or amoxiclav, whatever it is, depending on the clinical scenario, you start antibiotics. So these are the few common scenarios that we. So this I have spoken about how to recognize the common respiratory infections, how you manage these things. Do you need some antibiotic? Do you need some tests? And if at all you are giving antibiotic, how long you will give, how often you give, how much you give. So rational antibiotic doesn't mean that you don't give antibiotic. You have to give antibiotic when it is required. You should give when it is required. You should not give when it is not required. That is the main theme of what we call the rational antibiotic. And when you give antibiotic, you ask yourself, you try to question yourself whether really the antibiotic is needed, and then answer a few questions. What to give, which antibiotic to give, when to give, how much to give. You need to know the dose, how long to give, and which route to give. Not that little 2 days fever doesn't come down, people give IV antibiotics, which is not required. Oral is as good as IV. Having said that, let me take you briefly around about the AWARE classification. And this has been specifically requested by the organizers and the moderator that I need to speak on aware classification. It is really very good thinking of them that we need to talk about the aware classification. So what is this aware classification? Aware classification is a useful tool for monitoring the antibiotic consumption, defining targets and monitoring the effects of stewardship policies that aim to optimize antibiotic use and curb antimicrobial resistance. That means it is a kind of monitoring the antibiotic consumption. This is being recommended by the WHO. So what is that? We will go into detail. A means access, W means watch, R means reserve. So there are some access group of antibiotics, there are watch group of antibiotics, there are a reserve group of antibiotics. So access group indicates there are antibiotics which are commonly accessible and they are for common infections in the community. And these are available. It should be available at all time. They should be affordable and quality should be assured. So that is about the access. Access, it is accessible easily. The second group is a watch group, which includes highest priority critically important antimicrobials, and that includes not only human, even veterinary use, and it should be used only for specific limited indications. Whereas the reserve group is one that should not be available to a general group of doctors to be used. It should be reserved only for those cases as a last resort when all the other antibiotics have failed, who has MRDO, that is multi-drug MDRO, multi-drug resistant organisms. So aim of this WHO ever antibiotic categorization is to provide a tool to use antibiotics safely and effectively. This is again a short form of that. That it's a pyramid wherein access antibiotics are available easily and more, whereas reserve, it is very small amount and only in complex infections. So access antibiotics have a narrow spectrum antibiotic. They have a lower cost and they have a good safety profile and low resistance potential. This is used as a first or second line option for common infections, and they should be widely available, affordable, and the quality should be good. Watch antibiotics are broader spectrum. They are little costlier than the first group. They are recommended only as a first choice for infections where the antibiotics are likely to be resistant to access group of antibiotics. For example, upper urinary tract infection, wherein ESBL has come or something like that. Only in limited indications we use. Whereas the reserve antibiotic, as I told, it's a last choice antibiotic to treat the MDR infection. They need intense monitoring and it cannot be done given to everyone. And it should be used only in a specific patients. So globalization of the aware classification has been used in many countries and hospitals also worldwide. And it has helped to promote the rational usage of antibiotics and while improving the access to the essential medicine. And one example of this classification is it acts as a good tool to study the pediatric prescription data across 56 countries. There is a huge study across 56 countries. And in that point prevalence survey, what they found is that in Mexico, there was a high use of reserve. I thought it was India when I read that particular thing. But Mexico were one step ahead of us. And this could be due to, one is there is a lot of prevalence of MDRO in that area, or there is a easy availability of second or third line antibiotics, wherein the antibiotics, the infections which could be treated with the access group or watch group, then they were using irrationally. So this is the study of the various countries. And if you look at the Mexico, the red one, the dark red one is a reserve group of antibiotics. Compared to all the countries, the Mexico has a huge number of red line. That means the reserve group antibiotics have been used very much. Whereas in India, of course, the reserve group is misused, but compared to other countries, we are a little on the better side, but it should be nil, something like Kazakhstan or even Lithuania. All these countries, they are not using at all, and it is not available also. So that should be our aim. Though we are much below Mexico, Mexico stands high with these antibiotics. So it also shows pattern of prescription in various countries. But these data have been used to support the local or national antimicrobial stewardship activities. It can be used at a country level for benchmarking purpose between different countries. So you try to classify them and put it in some grading so that those countries who have worse grades can definitely do a lot to reduce that irrational antibiotic use. And it also, with the aware classification, antibiotic policies and guidelines can be used to monitor the AMS activities. And this image can be used for local use, wherein they consider local disease burden and resistance pattern. This is the first one. And access antibiotics availability at all levels, and restrict watch group of antibiotics and reserve groups. Develop clear antibiotic policies. Develop national or hospital guidelines. Each hospital or each country should have national treatment guidelines. We have, but I think it is 2016 in India, where there is not much of difference after that. So we need to apply the stewardship activities for all. So WHO aims to use this classification to support the monitoring of antibiotic prescription and inform the AMS activities. And WHO's target was that by 2023, at least 60% of the prescription should come from access group. But 23 is already gone. We are in 24, but still we have not been able to achieve that target. So translating the antibiotic usage data into aware categories will definitely provide a valuable insight on how antibiotics are prescribed globally, and thereby it becomes a stewardship tool. So what is the way forward? The clinicians are facing a complex problem that needs a lot of interventions depending on the characteristic of the population and the resources. Multidisciplinary interventions are needed. It is not only human, even in agriculture, even in the veterinary science, they are using antibiotics, and that should be curbed. And we need to use more of the diagnostics tools, especially the molecular diagnostics, so that you hit the target, you have the this thing, you identify the organism and take a proper step. And deferred prescription or wait and see can have a positive impact. So audit feedback and computer programs in dispensing, they may help in the interventions. And there are a lot of scenarios for improvement. For example, elaborating algorithms, protocols, clinical guidelines, and consensus statements. All these things will definitely help you to achieve the goal of antimicrobial stewardship. Ultimately, clinician must not forget that prescription lies in their hands. This is the most important statement that I'm going to give. Clinician must not forget that the prescription lies in their hands, and improving that prescription is a huge effort. So to conclude, I will give some carry home message. The messages are: the upper respiratory infections are common. Most of them are viral. Most of them are trivial. Some may be bacterial, some may be serious. Irrational and overuse of antibiotics is a great concern. If you feel that it is a bacterial infection, start early and use always the first line drug. Use microbiology help more often. So thank you so much for your patient hearing. Thank you, sir.
Thank you, Bhaskar. It was an excellent marathon session. Marathon session, yes.
Bhaskar, Shenoy, sir.
Yes.
Sir? Sir, I got a few doubts, sir.
Yes.
Regarding the acute otitis media, actually, I will dose amoxicillin acute otitis media. So actually, because few study they said actually for otitis media it is amoxicillin 90 mg per kg per day. Is it to give higher dose or shall I give low dose?
Yeah. See, always that I mean, the discussion 40 mg versus 45 versus 90 always
90.
is there. See, 90 mg is always given to the penicillin intermediate resistant or penicillin resistant streptococci, that is PRSP. And in India, till today, the amount of PRSP is very less. So still we can go ahead with the 45. Only in Western countries, definitely, the incidence of these penicillin resistance is quite high. For example, if you look at even Germany, Japan, and most of the other countries, they are in the tune of about 45 to 50%, and some countries 60%. I was astonished to see that statistics. So in our country, till the penicillins, I mean, the streptococci are still not very resistant. So we can use, but if it fails, then probably you can escalate.
So the next question, actually, if the child is having suspecting a sinusitis, actually, when do you suspect sinusitis in a child? So as you said, actually, if the child is having nasal discharge for more than 10 days, are changing consistency, is it an indication for starting antibiotic, even if the child is not toxic or like this?
No. See, yeah. See, in children, of course, when the symptoms, they persistent or severe or whatever I told, 3 categories of symptom, and a new onset of fever. And new onset of fever, if it is there, then probably yes. If the child doesn't have fever, non-toxic, you can still just wait. Not that every child who has should be given antibiotic. It was not that meaning.
Actually, in a newborn, you will see the otitis.
I can't hear.
Sir,
No, your voice is not clear, sir.
Okay, sir. In infancy, if you see the bilateral hair discharge in a newborn, especially those who sulfate, should we start antibiotic in that cases?
Yes, that's what I showed in the chart. A child below, I mean,
Below 2 years.
below 6 months, we have to start even IV antibiotics, because the chances of it going into complications is much more. And if you see in a newborn, it is directly you have to start antibiotic. There is no waiting.
Because actually in ENT, they say because of station 2 dysfunction, they will have a effusion. So actually, only if the child is toxic, actually, advise antibiotic. So if the child is not toxic or only
I didn't
serious.
get your point, sir. There was some disturbance.
Good evening, Bhaskar da.
Yes, sir. Hi.
I'm Ganesh from Aurangabad.
Yeah.
It was a wonderful deliberation. Wonderful. You almost cleared everything that, we had a lot of confusions in case of AOM specifically, when to start antibiotic, when not to start antibiotic, because it is so easy to, say on theoretically that this is viral and this is bacterial, but when it comes clinically, it becomes really very difficult to differentiate between viral and bacterial. Now, in case of we always keep on saying that in case of dysentery, you almost, without even doing any investigation, you straight away start with an antibiotic, right? When you see a blood in stools, you always start, in case of diarrhea, when you see blood in stools, you always start an antibiotic, because you don't have to even investigate in that scenario. Similarly, is there any such scenario where you can, straight away start an antibiotic in case of AOMs?
Yeah, that's what the flow chart clearly has showed that in a child bilateral and below 2 years, toxic child, you should start antibiotic directly. There is no waiting. When it is not toxic after 2 years and unilateral, child is not having fever, you should wait for 48 to 72 hours. Only those children you have to wait. But if it is below 2 years, especially if it is bilateral, you have to start.
What would you initiate? What would you?
Hello.
Hello.
Hello. Can you listen
Hello,
me?
sir. Good.
I am Dr. R.K. Gulati from Kota, Rajasthan. How
Yes,
many
sir.
percentage of cases they are having penicillin-resistant streptopneumonia in India?
Yeah.
How many cases of penicillin-resistant streptopneumonia in India? Because in foreign countries, Vietnam 70% and some countries 40-50%. But India, these percentage is less, I think so.
Yes, that's what I told, sir. In India, we don't have a large scale countrywide representative study. The only good study which we have is from Vellore, Dr. Balaji's study, CMC Vellore, wherein they have found that the percentage of penicillin more than the resistant, intermediate sensitivity. So they are rising. In one study, it was about 30%, but I will not tell that it is representative of the whole country. It is only in that particular institute, probably the resistant cases came there and they could find more. But it doesn't
Why
mean
it is less in India? Why it is less in India? Why this percentage is less in India?
That answer is not there, sir. See, in children, what they say is maybe the antibiotics, they are not using that much of rampantly compared to other countries. Could be definitely. Maybe our rational antibiotic module and other things have helped in curbing the antibiotic. Whatever it is, there is no explanation, but they have found that. But on the other hand, it is said that the resistance pattern is more common in younger children. That reason being. Collection center की तरह रहेगी lab so. Admin, can you mute others when they don't speak? So, in those cases, in children, it is more than the older children. That is because one is the antibiotic use is more in children. Second, children harbor the colonizers as a colonizer in the nose for a longer time. Third, they undergo genetic transformation and they can get the resistant genes from other organisms that are there in the nasal mucosa. So these are the few explanations that is given why it is more in the children. Yeah.
Do we need high dose amoxicillin in these cases?
Sir, when you have raised a pertinent point in the sense the high dose amoxicillin should be used, when should be used, what is the rationale for using the high dose antibiotic, amoxicillin. Say, as Dr. Jog in the initial period told, the three major organisms are Streptococcus pneumoniae, H. influenza, Moraxella catarrhans. The resistance mechanism of these three organisms, the Streptococcus pneumoniae develops resistance by what is called as a penicillin binding protein pathway. And the other two, they develop ESBL, extended spectrum beta-lactamase. So the resistance mechanism of streptococci is different and these two other organisms different. Now, we have to look at how to overcome this resistance. When it comes to Streptococci pneumoniae, because it is by the penicillin binding protein defect, you can increase the dose of amoxicillin and overcome that resistance. Whereas for ESBL, it is only the clavulanic acid, adding clavulanic acid will take care of the ESBL. And proportionately, you need not increase the dose of clavulanate, because by increasing the dose to double also, it will not have any effect. The standard dose of clavulanic acid which you are giving is enough to take care of those things. So to take care of the penicillin resistant streptococci, you increase the penicillin that, because by increasing the clavulanic acid, you may even have more side effects like diarrhea. So, and it will not have any additional benefit on the ESBL. So this is the rationale for that. And when do you use? One is, suppose you have started with the amoxicillin and within 48 hours, if it doesn't respond, you have to. And second thing is, a child who has a persistent otitis or a resistant otitis or a recurrent otitis media, you start. Third is, he has taken amoxicillin or some antibiotics in the previous 1 month. So 3 months, sorry. So these are the few indications wherein you have to directly go for amoxiclav, especially the high dose.
Good evening, sir.
Yes, sir.
Hello, sir.
Bharinda.
Bhaskar sir.
Okay,
Yes,
Dr.
please.
Gaurav will continue.
Hello, hello.
Bhaskar sir.
Yes, sir. Please.
Bhaskar sir.
Yeah. Tell me.
So you said rapid antigen detection test is perhaps it has a wonderful sensitivity and a good specificity as well. But having said that, this after that, should we be following it up with a culture so that we know the culture sensitivity against an antibiotic, or only detection of antigen is important?
See, detection of antigen is more than enough. By doing culture only in some conditions we may do, otherwise routinely cultures are not recommended. And because of the high sensitivity and specificity of rapid antigen test, and even in US they do it routinely. So in a general practice, culture is not required. Only if you can have a rapid antigen test, that's more than enough.
Good evening, sir.
Hello,
Good evening,
Dr.
sir.
Shenoy.
Yeah, Dr. Gaurav from Bharinda, sir.
Yeah. Please tell me, sir.
Sir, there's any role of short course antibiotics in pneumonia?
See, there are some papers, studies which have come from various places. For example, even WHO had a study, conducted a study. And in Pakistan and another country, I think Nigeria or some African country, in a non-severe pneumonia, not in a severe pneumonia, in a non-severe community-acquired pneumonia, they did 7 days versus 5 days. Then there was another study, 5 days versus 3 days. And what they found is that they both are non-inferior. And they give the similar resolution, similar improvement. So, but it cannot be taken as a blanket this thing unless it comes from a recommending body. But there are many studies to say that in a stable child, a community acquired child, pneumonia, you can use the short course antibiotics are as good as a little longer course.
Right, sir. Thank you.
Dr. Manish Gupta has some questions.
Hello, Doctor. Yes, sir. Hello, Dr. Bhaskar Shenoy, sir. Thank you for a wonderful presentation, sir.
Thank you, sir.
Am I audible, sir?
Yeah, yes, sir. Yes, sir.
Okay. Okay, sir. The question is from here, an attendee doctor is in a 2 to 5 year category, difficult to
manage just with paracetamol, not giving antibiotic to that patient. We want to use now amoxicillin, but that is hardly available. Is the amoxicillin, how much it is equivalent if you use it without clavulanic acid or with clavulanic acid 1:14? Plain amoxicillin versus high dose amoxicillin with clavulanic acid, what the study says.
I didn't get your first part, sir. There was some disturbance. Can you repeat your question, sir?
Yes, sir. The first part is in a 2-year and 5-year-old category, if you want to manage conservatively a non-severe otitis media, just giving paracetamol, not giving antibiotics, practically at clinic, it is difficult to manage that way. As the guidelines say, you may wait for 48 hours in non-severe otitis media. So that is the question, sir.
Yeah, say I do agree that, but initially I too had, but once if you take RTI GEM module, no, that is an excellent module wherein you have answers to all those things. Now, initially it is difficult, but it depends on how you convince the parents. Parents may not agree initially, but most of the patients in my practice, at least, they agree to that. And you convince that it is non-severe. Not that I don't give antibiotic. I may give antibiotic if these are the things. One is child develops fever, child develops pain becomes more, or some discharge is there, or if there is no improvement even after 2 to 3 days, then you come back. So that's how we convince the patients, and then we go for antibiotic.
Right, sir. And the second thing is increasing the amoxicillin dose from 40 to 90 milligram without adding clavulanic acid. How does that compare with making high dose amoxicillin with clavulanic acid? Just plain amoxicillin high dose versus high dose amoxicillin with 1:14
Okay,
clavulanic acid.
No. See, that's what I told in the previous thing. It is the plain amoxicillin. If you increase, it will take care of only those Streptococcus pneumonia who are penicillin intermediate resistant or penicillin resistant. Because increasing the dose of amoxicillin will help to take care of those resistant Streptococcus pneumonia. But this clavulanic acid will take care of the ESBLs produced by H. influenza and Moraxella catarrhalis. And this concept is not new. If I tell the story of that, even in US long back, maybe around 40s or 50s or 60s, when the amoxicillin first came into the market, they also knew that by increasing the dose of these things, maybe around 70s or 80s, increasing the dose of amoxicillin and keeping the clavulanic acid in the same proportion would definitely help in these resistant cases. So that time, this ES preparation has come only recently, isn't it? And that time they didn't have that preparation. So what they used to do is they give 1 dose of amoxiclav and 1 dose of plain amoxicillin. You understood my point?
I also used to do it in last 3-4 years back, because 8 years back actually enhanced spectrum came, then it was withdrawn.
Yes.
So I was doing this in last 4 years.
Yes, sir. When it was not available, the ES formulation, people in US long back used to do, and what you told is absolutely right.
Hello.
Thank you, sir. Thanks a lot. Thank you.
Thank you, sir.
Hello.
I think Dr. KK Joshi, I think he was trying, I think at the
Yes, sir. Please.
meet and greet session also, he was trying to talk to you, sir.
Any role of, yes, Dr. KK Joshi from Kerala.
Please.
Any role of short course antibiotics in pneumonia?
Yeah, that's what we discussed. As I told, there were some studies in WHO sponsored studies and other studies wherein they compared a 3-day course with versus 5 days course, and they found that both were non-inferior. And it is only in a stable case community setting, not in the hospital setting. And it cannot be taken as a blanket recommendation, only a study. And probably when more evidence is there, they may make it as a general recommendation. There is a role. In Pakistan, they have done a study. In Nigeria, they have done.
Yellowish nasal discharge, does it indicate bacterial infection?
Sir, please.
Yellowish nasal discharge, does it indicate bacterial infection?
Oh, yeah. See, all yellowish nasal discharge will not indicate a bacterial infection because the designated WBCs which are there in the nasal discharge, they can cause the color yellow. But only if the child is having high fever, toxic, along with that yellow fever, then you can take it as a bacterial. But if the child doesn't have fever, child is otherwise not toxic, but only yellowish discharge, it doesn't indicate a bacterial infection.
Hello,
Hello, yes.
audible? Am I audible on?
Yes, sir. Yes, sir. Dr. Reddy, please go ahead.
Just I got a basic doubt. So, when does sinuses become pneumatic from sclerotic or get aerated? So the minimum age for maxillary sinus and frontal sinus, as you are telling, an infant of 1 or 2 years, you are suspecting a sinusitis. Is it justified to suspect sinusitis in a younger child of that age group? First one. What is the younger age? The maximum what age? So youngest age you can diagnose a maxillary sinusitis and a frontal sinusitis.
Sir, the sinus development varies with the age, and usually the ethmoid and the frontal sphenoid sinuses may be developed at birth.
No, I am asking maxillary sinus.
Maxillary will take about 5 to 6 years.
Sphenoidal sinus or ethmoidal sinus?
The maxillary will fully develop by 5 to 6 years, not earlier than that.
Frontal sinus?
Frontal side about 2 to, I think it's 2 to 3 years.
No, it is in the adolescence. 14 years.
Sorry, frontal is adolescence. Others are
usually allergic. Secondary to allergic is ethmoidal. And sphenoidal, we don't know the etiology. So for making a diagnosis of sinusitis, the youngest age is 6 years. You cannot make a diagnosis of sinusitis in a 2-year child. And you cannot make a diagnosis of frontal sinus unless there is a throbbing headache, it is related diurnal variation, and other things, then only you have to make a diagnosis of frontal sinusitis.
Yes.
Is it correct or not?
Yes, sir, you are correct. So the maxillary sinusitis cannot be diagnosed even before that. So it's only 5 to 6 years only we have to do it.
And the thing is, so
yes,
the etiology of the acute otitis media, 33% are staph pneumonia, streptococcal pneumonia. 33% is Streptococcus aureus, Staph aureus, Moraxilla catarrhalis. These are the in order of priority, the etiologies according to the standard textbooks. That also reflects in our that. But for all the 4 organisms, so how to differentiate one from the other?
It is not possible. See, the best way would be to take a mid-layer fluid sample and do, which is not practical. And even for study purpose, doing a mid-layer sampling, mid-layer fluid sampling is not a practical thing. And most of the parents do not give consent for that. Only in one, I think in Ron Drogan from Iran or Iraq or somewhere, he had done about 240 or so children. And small studies were done here and there. But there is no large-scale studies on the mid-layer fluid microbiological studies. It is only the what you call, see, sometimes they, with the respiratory infection, they get some organism and they give. But otherwise, ear infection, perfectly mid-layer fluid study has not been done in a large scale. Whatever studies we have, is small here and there, institutional studies.
Okay, so Dr. Ravi from Bidar wanted to speak to you, sir.
Yeah, please.
Yeah. You can unmute, sir.
Madam Magalingam sir from Tamil Nadu.
Tamil Nadu. Hello, I'm audible.
Yeah.
Madam, I'm audible.
Yes, Ravi, you are audible.
Yes, sir. Sir, one question asked from the audience also. So what they are asking is, sir, if we are waiting for 1 or 2 days, first day patient comes to us, so we are not giving antibiotics. Second day also they came, we are not giving antibiotic, we are waiting. And if it third day or fourth day it deteriorates, then anybody can protect us from that medically legally.
Yeah, you can always say, if you convince them on the first visit, definitely things are going to be very easy. First day, second day, I have been doing it for the last many years and I have not had any problem. But it is important that in the first day, first visit, you should spend more time and convince them that at this point of time, antibiotic is not necessary. I will wait for 48 to 72 hours. And after 72 hours in between, if you experience that the pain is severe or some discharge is there, or if the child develops fever, all those things are toxic, not improving, you come back. I will start antibiotic. So starting on first day is not rational. If you tell 99% of our patients will agree. The only thing is we have to spend little time and convince them that this is the situation. Most of them will agree.
Yes, sir. From our side, we will do. So what I want actually is, any of this AMR is a growing problems throughout the India and outside the world also. So if government comes to our support in such cases, that the first day, second day, any of doctors are not starting antibiotic. So ours is a bigger body. We can convince them that like that. That is the question.
Yeah. Say always when suppose if there is a court case or if there is a legal issue, if you have a standard recommendation from any of the, definitely you will be protected. You can always quote that standard recommendation. See, whatever I have told also, it is not from my thing. It is from either from some books or from some guidelines, maybe IAP guidelines, maybe some books. So if you quote that, whatever I have told, whatever I have discussed today, nothing is outside the standard textbooks or IAP guidelines.
Thank you.
Hello. Sir,
hello. Yes, madam. Good evening, madam.
Sir, I just want to know, is there any role of local antibiotic in ear infection, otitis media?
No. Local antibiotics are not recommended in this thing. Only in a chronic or pseudomonas they recommend, not in acute otitis media. In chronic discharging, sometimes they recommend, but not in acute otitis media. Even role of analgesic ear drops also is questioned.
Okay. I think Dr. Mahalingam wanted to ask.
Yes. I am from Tamil Nadu, sir.
Yes, sir. Yes, sir.
Hello, is it audible?
Yes, sir.
We are much talking about that upper respiratory infection only, but we are not much concentrating on the lower respiratory tract infection. In this discussion, at least. My question is simple. Procalcitonin versus CRP value for diagnosis and therapy, sir. At least in fulminant case of pneumonia, it's going to be very much useful. Either this procalcitonin versus CRP, therapeutic as well as diagnostic.
Yes, sir. Yes, sir. See, first of all, the time given was everything. I had to cover all. And in between, I made a mention of pneumonia and lower respiratory. Okay. Now, your question is very valid, sir. CRP versus procalcitonin. Actually, the CRP is a general thing. cannot help you to differentiate between a bacterial and a viral infection. Only in inflammatory conditions, it can be very high, something like Kawasaki or something like inflammation, autoimmune, it can be hundreds or MIS-C and other things. But all other things, whether it is bacterial or viral, a little increase will be there. So CRP will not help you to make a differentiation between a bacterial and a viral. Whereas the procalcitonin can help you in telling you whether it is bacterial, because a highly elevated procalcitonin will definitely go more in favor of a bacterial. And in viral, a procalcitonin will always be negative. And the other thing is the procalcitonin starts rising very early. It is the early marker, whereas the CRP takes a little longer time to rise.
Dr. Bhaskar sir, there is one small query from our attendee doctor. How common is acute otitis media in 1 to 3 month old child? If a 2-month-old child comes with discharge in ear, what would be the choice of antibiotic in that category?
Yeah. See, I didn't go through that huge list of antibiotics in various age groups and various conditions. But in a baby less than 6 months, you have to be very proactive. You have to directly go for antibiotics, preferably intravenous. It can be amoxicillin, or ideally it would be ceftriaxone. Ceftriaxone is a better thing. And you have to start within 6 months child, you have to start antibiotics. IV especially.
Thank you, sir. Thank you.
Yes.
Sir, what is role of mother feed in otitis media?
Pardon? Role of?
What is role of mother's feed in otitis media? Does it provide any protection? Breastfeed, sir.
Yes.
Breastfeed.
Yes. No, the studies have definitely showed that bottle-fed babies have more chances of otitis media compared to the breastfeeding. And some people advocate that the position which she holds is also very important, especially when she feeds. The head portion should be little up, all those things. But in my experience and some of the studies I have seen, the difference between the bottle-fed babies are always having a higher incidence of ear infection. Yeah.
I think, Bhaskar, most of the questions are probably covered.
Yeah.
And
hope you don't have any questions.
No, I will not ask because I am sure you are exhausted now. Yeah. Anyway, so we will now slowly conclude the main session, but the group discussions at the respective places can continue, and our esteemed chairpersons can continue to answer the queries of the delegates who are attending. So from our side, both of us, myself and Dr. Bhaskar, thank all the regional chairpersons, also microlabs, Dr. Surekha Kale in particular, and her colleagues. And then if at all you agree, then maybe we will leave the meeting and then the groups at the respective places can continue to discuss.
So thank you, Dr. Jog, for inviting me and moderating this session. And thanks to Surekha and team and Dr. Vanmati and whole microlab team for the excellent organization. And the concept, I should definitely, it is, I think, a joke's concept it must be. So the concept is very good. The way they have formulated is very good. And thank you very much for being the part of this excellent program. And I thank all the chairpersons and the attendees who have gathered here. And without you, probably it wouldn't have been successful. And the wonderful discussion and the active involvement was more bringing happiness than anything else. Thank you so much.
Yes, sir.
Good night.
Sir, allow me to speak for 2 minutes. I would like to share good news that we are really happy to share that, sir, all India 2000 plus pediatricians were registered and joined today for this Bhaskar Pediatrician Pathshala Module 2, sir. And we, Bhaskar Microlabs team, would like to thank all the participants, pediatricians who joined us today for Bhaskar Pediatrician Pathshala Module 2 virtually. And we are extending our heartfelt gratitude to pediatricians who joined us physically at 20 different locations or 20 different centers, along with regional renowned moderators who will be extending the session after we winding up this online webcast. And thank you, Dr. Vanmati, for your warm welcome to all our guests. And now, Dr. Bhaskar Shenoy, thank you so much for your long association with us, sir, and offering one more enlightening and enriching session today. And it would be always an honor to share the platform with you, sir, in Bhaskar Pediatrician Pathshala. And thank you for sharing all your expertise always with us and today also. We look forward to collaborate with you again in future also, sir, under Pediatrician Pathshala.
Thank you so much.
Last but not the least, we would like to express our strong bond and association with our beloved Dr. Pramod Jog, as Dr. Bhaskar Shenoy rightly mentioned, that we can say he is the mother of this concept of Pediatrician Pathshala, wherein we offer,
Father.
Dr. Pramod Jog, who is scientific coordinator and national coordinator for all our Bhaskar Pediatrician Pathshala initiative, who always moderate the session on greater and lighter note. Once again, thank you all for your wonderful presence and participation today, which inspires excellence in healthcare. As our motto of Pediatrician Pathshala is excellence in pediatric care. So thank you so much, everyone.
Thank you, sir.
Thank you.
Sir, Bhaskar Shenoy, sir, Pramod Jog, sir. Thank you very much, sir.
Thank you. Thank you, everyone. Thank you. Thank you.
Thank you.
Bye.
Thank you.